I think we've listened to 4 really outstanding presentations. Before we bring the panel up, let's just set the stage and sum up a bit. What we essentially have been discussing today is not letting the perfect be the enemy of the good. We clearly have seen that CT is superior to chest X-ray, but for a long period of time, we've dismissed chest X-ray. We've actually allowed the interpretation of the trials to pretty much wash our hands of chest X-ray. And yes, as you've seen today, and many people have noticed over the years, chest X-ray is not useless. In fact, the numbers show that it actually can find some lung cancers early. We also heard presentations today showing how much the chest X-ray technology has evolved with the digital tomosynthesis, especially with the AI. One thing we do need to talk about is that through the proliferation of AI, you've seen one eye, you've seen one AI, you've seen one AI. But with lung cancer being the leading cause of cancer death around the globe, there are opportunities in settings where CT cannot be affordable, or where it's simply not in sufficient presence to accomplish something with chest X-ray. It looks as if that's truly possible. In 2003, Ben Anderson decided to take up this issue with breast cancer. This ultimately led to the Global Breast Health Initiative. At the first meeting, the primary emphasis was that even though you do not have mammography or cannot afford mammography in some settings, it's absolutely critical to try to introduce at least state-of-the-art therapy, diagnosis and therapy for breast cancer, because the breast cancer was still prevalent in every country in the world. At that meeting, we tried to emphasize that downsizing and downstaging a palpable breast cancer could also accomplish a great reduction in mortality. Treating a 1 centimeter or sub 1 centimeter breast cancer was going to be a lot more successful than a 4 to 5 or 6 centimeter plus breast cancer. And so the idea began to evolve that you really could, until a country could afford mammography, there is no reason not to really try to promote early detection of palpable tumors, earlier detection of palpable tumors. So I think we find ourselves in that same situation today. We heard really a very nice talk about how to think about the cumulative data on chest X-ray to date. In 1980, actually, the American Cancer Society, in what was probably the very first application of evidence-based medicine to cancer screening guidelines, dropped the recommendations for routine lung cancer screening with chest X-ray. And then some years ago, it actually worked pretty hard to promote the idea that we needed a randomized controlled trial of low-dose CT, which ultimately came about. And in 2015, actually 2013, we had the first, I believe, breast lung cancer screening guidelines. The task force and ACS and then other organizations followed. I think actually NCCN was earlier than that, 2012. We heard some really exciting news about the potential of AI to truly benefit detection, improving accuracy, reducing fatigue. One of the most remarkable AI studies I've seen recently is the adenoma detection rate in a GI screening facility for colorectal cancer, and how over the course of the day, the adenoma detection rate plummeted as the gastroenterologist got tired, fatigued, and they showed by using the AI tool, it stayed at the same rate from 7:30 to 8:30 in the morning all through the day, which is a reminder to everybody, if you're going to get a colonoscopy, get the first one in the morning. Tomosynthesis clearly shows advantages to overcome the disadvantage of overlapping structures, bone and tissue and organs. And the integration of a combination of chest X-ray, the potentially, and CT, I think would be a real challenge. And as these questions that we've pulled together for the panel today are wanting to address is, how do you integrate these things together? How do you avoid settling for chest X-ray when you might want to continue to work to pursue the availability of CT? Is there actually a very effective way to coexist? I would imagine in the US, where lung cancer screening rates are really quite low, there are hundreds of thousands of people who are eligible that are getting chest X-rays and not getting CTs. So we have a great deal of work on our hands. So enough from us. Can we invite our panel up to the dais and we'll get started on our discussion? Yeah, come on. So our panelists today are Harry de Koning from
stay here, I guess.
Erasmus University, David Yankelevitz, who you all know, and Jay Vogel-Claussen.
New name tags. Do we have
Who's been up here before, and Rudolf Huber, who you just heard speaking.
Good to see you.
So
too.
we have some questions
Good to see you.
prepared.
Good
I'll
to see
go
you.
ahead and kick this off, and then Claudia and I will share this. So has chest X-ray been underestimated in those prior randomized trials, including Mayo, PLCO? What are the opinions of the group? We heard some interesting presentations, but how should we be thinking about it and discussing it going forward?
May I start? Good afternoon, everyone. So indeed, I think basically the past trials, the early trials on chest X-ray were simply, let's say, designed incorrectly. I would say now, of course, and they don't give an answer basically. The NLST and the PLCO data, they may seem sort of negative, but you can really use those data to come up with estimates on sensitivity by stage, even so, because you have high quality data and you can compare what was going on in the US, as one of the slides showed on the survival difference, for instance, but you can really look at stages and so on. So actually, some time ago, we were able to get the NLST and PLCO data. And we come up with that indeed there is a sensitivity by stage and by histology. And so the question is underestimated, yes, because you need a bit more methodology to be able to come up with these kind of estimates on sensitivity. You cannot get indeed I think the results basically show something like a 5% lung cancer mortality reduction even in those trials, if you are being able to compare it with the baseline situation in the US. So yes, there may be a role. At least it is effective, I think, to some extent.
Yeah, I'm very much of the view that it was underestimated and perhaps even severely underestimated. I think the whole point of any screening in the chest is you can think of, I think you think of the size as the surrogate for how curable the cancer is. Ultimately, you don't get any mortality reduction or fatality reduction unless you prevent death from some of the cancers that you find with the screening. That's the whole point of screening. And you prevent more deaths, the smaller the size. More smaller size tumors are more curable than bigger tumors. And I think it's a very, chest X-ray finds smaller tumors than waiting for them to present with symptoms. So they're not as curable as the smaller size that you find with CT scan, but they're substantially more curable. And I think if you just look at it that way, then everything in my mind falls into place. If you have a chest X-ray and you apply AI, you'll find it a little smaller typically than the human will find it. If you do tomosynthesis, you'll find it again even a little bit smaller than that. And if you do CT, you'll find it smaller. And if you just think of it as the size as the surrogate for curability, I think that's, to me, that's the whole answer.
And adding to that, I was also very impressed on the tomosynthesis results. And it's an increased sensitivity, as you explained, but one should do the whole calculation. One should do a holistic calculation, because what's the added healthcare cost, right, of an advanced cancer or catching it very early with CT? So this needs to be into the equation, not just, oh, it's cheaper to do a chest X-ray, right? If there's significant stage shift between the CT and the chest X-ray, one need to calculate the sink cost, right, of the gap. And this has to be also calculated on a population. But nevertheless, I think that the opportunistic screening with the chest X-rays done, what I really liked your talk, throughout the world, especially also in Germany. One needs to use it and maybe use it more effectively with AI, with training, because I'm sure there's a large dark number where we miss smaller or smallish cancers by untrained radiologists.
Regarding the results from there are these methodological issues which were just mentioned, but we have also another situation now. We had at that time much more smoking-related cancers than now, and we had at that time much more squamous lung cancer than now, and we had not that advanced surgical techniques. So also patients didn't get surgery because they were not operable at that time. So many things have changed. And I believe, therefore, we have to reconsider it.
So that, so do we really think that the randomized trial is necessary at this time?
So no, I don't think we need another randomized controlled trial on the chest X-rays. I think one of the talks was about comparing the detection rates, for instance, and the stages of different modalities, like the tomosynthesis versus the chest X-rays versus the CT. I think that is very informative. I think if you have a randomized controlled trial like the NLST and the Nelson on CT scanning, and you know the natural history of lung cancer, then another test, you don't need a complete new randomized controlled trial, I think. No.
Yeah.
In a certain way, the NLST or the Nelson, you can look at those trials, and in fact, it's very explicitly said in the NLST protocol that really what they were trying to do is prove that finding a tumor that's smaller is better than finding a tumor that's larger. They're very explicit about it. They say we don't know whether finding a tumor when it's 2 millimeters is better than finding it at 2 centimeters. That was the hypothesis behind the NLST.
You just
Very
turned it off
explicitly said.
again.
So insofar as
Is it off
that was
again?
a necessary
turned it off.
hypothesis to test, the NLST
Oh,
absolutely
turn it on
proved
again.
that it's better to find tumors when they're smaller than when they're bigger. Nelson, you can view in the same way. It showed that finding tumors with CT was better than finding it by, waiting till they present with symptoms.
Hello.
So if you view it in that way, that smaller is
so
better.
I
And
was
the
going
chest
to just say
X-ray
that.
obviously finds it smaller and better, just not as small. And so I think that's, so yes, I completely would agree with Harry and say that there's no need. We can look at the various sensitivity of chest X-ray. You can look at the overall cure rate of the larger size tumors that you find with chest X-ray compared to CT. And you get all of the answers that are really necessary to make the determination that chest X-ray screening is useful, just not as useful.
Adding on what you just and adding what you just I think that CT technology is evolving from the first NSLT trial until the photon counting today. So those, I'm not hitting any, okay. The radiation are going lower and the quality is going up at the same time. So I think CT is evolving, and I think the availability of CT is increasing as well. So let's keep on sort of pushing and moving who has the best sensitivity for smaller nodules also, and specificity in what you said as well. I think where the field is moving, say, right, we keep CT for the next 10 years as the only screening method, because I think we hear about it in the next sessions, that combining it with other methods may be a good ally to do new research on. For example, combining it with blood test biomarkers as well, and improving our CT algorithm that they're so good that they can be applied in an age-based population and dropping the risk, maybe, right? Like we've seen in Taiwan or in China, where there's screening in China, depending on your insurance, starting from the age of 30. So depending whether you smoke or you don't smoke, right? So I think this is the way we need to move on, and not to go for randomized control trials with chest X-ray.
Yeah. So we're making some progress. No RCT, but we have this question, right, that we've already seen. We're seeing some systematic reviews. As some of the speakers have indicated, there's been a proliferation of articles on AI. There's been a proliferation on AI applied to chest X-ray. There's a lot of new literature coming out. And in many respects, it's not in the kind of journals that it needs to be. So one question we have is, how would we go about getting this recognized, chest X-ray and chest X-ray with added technology, as getting recognized as a potential real game changer in settings that cannot implement CT? How do we actually think about the various layers or implementation of chest X-ray technology? We've really heard four options today: chest X-ray, and digital tomosynthesis, plus or minus AI in any of those contexts, depending on what might be affordable, but it probably all would be beneficial at the lowest level to the highest level. Is that something that this group should take on and throw its weight behind? You're looking for projects, David, I know. So
It would be really good to do trial with artificial intelligence and chest X-ray, and then if we want to do it in a randomized trial or controlled approach, we could then use afterwards chest CT and compare that.
I would take a slightly different view than that. I don't think that we want to do any randomized.
I'm sorry,
for chest
did you hear or repeat?
I think AI improves the ability to find smaller nodules, and I think tomosynthesis improves the image somewhat and allows you to see smaller nodules. And I think I think we get lost too much in trials proving things. I think we've proved enough that smaller lung cancer is better than bigger lung cancer. It's just how much smaller you get with AI and how much smaller you get with tomosynthesis. I think one of the things that really strikes me is when I listen to Rudolph's talk, the number of chest X-rays that are done in Germany per year. And they really are, as he said, they're basically screening tests, looking for something in the heart, looking for something in the lungs. They did, what was it, 5 million chest X-rays in Germany in the last year or something. That's probably more than all the screening CTs in the world in that same year. They're doing it in Germany alone, chest X-rays. Can you imagine how many cancers we're missing by not looking? Vietnam, I know, also did something like 5 million TB screenings or something, and they're not even looking for nodules in half of these. So, I think there's just an enormous amount that we could get at right now that we're not. And, I do think the AI helps. And I think, I really think that we would be finding a lot. I mean, we already know that you find clinics in hospitals are finding more cancers in their incidental nodule programs than they are with their lung cancer screening programs. I think if you look at the chest X-ray programs that are going on, the number of early cancers you would find would also be quite enormous. And I think we shouldn't miss that opportunity to get at them.
So of course the question is, why are there so many chest X-rays done in the world? Of course, so I do think it is, as Bob said in the beginning. I think each country or region, of course, should first try and to set up a CT screening program. And let's be, I think, clear about that. And they have to have good reason and arguments and cost assessments or etc. etc., to really say, okay, this is simply undoable for us, and do we have an alternative? I think we should not go away from that. I think. And then maybe do the best thing, and maybe tomosynthesis or chest X-ray with AI. And Bob, you just mentioned, indeed, as a comparison, we know in breast cancer screening, there is also the AI as an additional tool. And they did do a randomized control trial on breast cancer screening with and without the AI. So to some extent, maybe you could argue you need something like that still. Because the alternative would indeed be something like, as we've seen, maybe that the same individual has to have two tests, for instance, one I don't know, one tomo or one chest X-ray with AI to show the difference. And there are, of course, issues in that also, because you get double the dose, etc., etc. So that would be an argument to still do a randomized control trial to show, for instance, how much more AI is beneficial, let's say, in a chest X-ray. But again, it's really setting up a new program. I fully agree. If you do so many chest X-rays in the world, why not also look for screening? But we all know how difficult it is to get that into practice, to get the radiologist then look differently, to look as a screening as a screening protocol and not at a diagnostic protocol, maybe.
So, but there are only limited resources of people and doctors and trialists and so on. So why would you spend money on doing a randomized trial for AI rather than implementing low-dose CT and making sure that you do a nodule detection program along with it, that you would enter?
You don't have to repeat the tests with the chest X-ray and the AI.
No, then not. Sure,
It's
sure.
just
That's clear cut. But
that lung cancer low-dose CT is the better method. But I really advocate for that we are not missing the incidental pulmonary nodules which can be detected by chest X-ray. This would be, for me, the most important message.
So that should be integrated. You're suggesting it should be integrated with a CT screening program, that you have a feed in from incidental,
Yes.
that you bring, that you
And
highlight the other contributions.
yes, and when you are speaking about AI, then you can also use AI for tracking the patients who have an incidental finding on chest X-ray. So this, I believe, should really be implemented.
Yeah, I just do a comment why there are so many chest X-rays done in Germany, because it's the, you please correct me, I'm only a radiologist, but I worked in many hospitals, even in the US. But the thing is, it's an extended exam in the ER, right? Extended, I'm not sure. Maybe this is better. It's an extended exam in the ER from the physician, right? They just ordered this like a blood test, right? It's easily accessible, and a triage for treatment, right? Which ward they're going to. You know, the symptoms, he has a big heart, or the lung, there's effusion, heart failure, and all that. So I think it has its merit. We're researching at the moment how we can replace it with very low dose CT, because dose is an issue in Germany, right? We just can't exchange a method with a higher dose method, but we could show with the photon counting. I think in the Siemens session, they showed the paper that at the same dose of a PA and lateral chest X-ray, you may not be good to do lung cancer screening and do volumetry, but you certainly can see 6mm nodules, and you have much more information at the same dose. Then why we're not doing it? Because even in Germany, we would not have enough CT scanners to replace all the chest X-rays.
So this is not part of our list of questions. Let me just throw this out. In the US, David, you can tell me if this is a fair conclusion, there was a great awareness that we were leaving nodules unaddressed that had been picked up on CT for other reasons. And that eventually those patients would show up with an advanced lung cancer. And so now we have a fairly rapid growth, tell me if that's not true, of nodule clinics where they're recognizing that we have to act on those nodules that we see incidentally, even if this examination is being done for something else. It sounds to me like the same is true of chest X-ray, and yet it has not actually reached to that point where it's sort of, you do the exam for one reason and you ignore all the stuff you find if you don't see that one reason. And it may be that we need to sort of alert the world, if you're doing chest X-ray, you know, to have a plan to survey, watch those nodules or act on them. Would you agree?
But you're right. Then your first question was very valid. That I guess the thoughts are okay that we have had randomized control trials and they didn't show anything. So we have to still work on that, I presume, before you get so many individuals saying, "Oh yeah, let's look carefully at the chest X-ray." I presume, because we are academics and we looked at the data, et cetera, but probably in the mindset there is maybe still the issue of we did do randomized control trials, they didn't show anything. So I it's probably a bit more difficult than we might think, but I don't know.
There's you know I have a little bit of a counterpoint to that. You know, we all accept the idea that if a person gets a chest X-ray for whatever reason, and there's a nodule found on that chest X-ray, say it's 2 centimeters or whatever. Once that person presents with a nodule, nobody in clinical medicine says, you know, randomized trials didn't show a benefit, let's not work up that nodule. You have a nodule, you must work it up, no question about it. And if that nodule turns out to be cancer, you must treat it. Nobody questions that. They only question whether or not you should actually have gotten the chest X-ray to find the nodule, which to me is not so much a question as to whether it's worthwhile finding the nodule. It's a question of, you know, maybe it's not frequent enough. It's an issue of cost, but it's not about the worthwhileness of finding the nodules. Everybody should understand that once you've made the decision that anytime you have a nodule, it's worth working it up. And if it's cancer, it's worth treating. Then we already have established that we know that those are worthwhile finding. It's just a question of whether or not it's sort of, you know, from the situation of cost or overall risk, where the society wants to invest the kind of money to look for it. But we've already established that we know that if you have a nodule, it's worth treating it.
I may add on that in Germany, it's even relevant in court, I have to say, because but there, it's if you see a nodule, usually I agree with you, it's worthwhile to work it up. But I think the main thing is that it's not detected, because as I said before, the radiologist didn't see it, didn't pick it up. And I think we have this issue on chest CT, right, where we know that even trained radiologists miss up to 15% of relevant nodules without AI, right? AI solved that problem to a large extent. We're very grateful on that. And so I think we should relook and revisit chest X-ray, having the help of AI in the future to have this detection problem, which I think it's a larger problem in the intermediate and smaller nodules than with CT. And that's the first thing. And the second thing is, in Germany, it's always worthwhile to follow up those non-calcified nodules if detected on a chest X-ray, because if it's not actioned on or not mentioned in the report, it may end up in court when you see the nodule has grown, and it's a court issue. It's a legal issue.
No lawyer has ever made the case defending a radiologist who missed a nodule. No lawyer has said, listen, randomized trials didn't show a benefit, so it didn't matter if he missed it. That's not a defense, you know, because we know.
Lawyers are not so academic.
Some of them are.
Yeah, I don't really, but just to try some things. The things here, this,
I think we're discussing two different things here. One, like using the chest X-ray for screening in case a country doesn't have the availability to chest CT scans. And one, what we do with the chest CT in clinical practice, because we make so many. I think I agree with you that we should use all resources to get as much from the chest X-ray that we are already doing as possible. So if AI helps, use AI and get the message out. And I agree that we don't need an RCT for that. But regarding using a chest CT for screening, I think that's a totally different discussion, because I can imagine if you don't have the resources to do chest CT scans and you want to do a population-based screening, I think it's more than just getting a CT scanner for doing a population-based screening. I think 90% is like work around the chest CT scan, maybe even 99%. So all the administration to get the people to get the people, the right people. We can, even the countries that have the resources can get the people to their CT scanner. So I think there are two very different discussions going on here. Just interchange them.
Yes, absolutely. I mixed it also in my talk, but I believe I made it clear these are two different parts. And I would like to add about AI and chest X-ray. The trials which are looking at sensitivity and specificity, they use trained viewers. In reality, chest X-rays are usually seen by the least experienced viewer in the real daily practice. So the AI could help a lot.
I think I think there's a quick win here that is underestimated. I think if we upgrade all the chest X-ray systems that we have, for example, in Germany, but we have them worldwide, widely applicated now, it proves that it is a major improvement. So I think recommendations, apart from screening, that we can improve healthcare worldwide by just promoting tomosynthesis first and then AI, because I think AI will gain a lot of tomosynthesis and will become a lot better even if we do first the hardware upgrade. And that can be of extreme cost-effective benefit for anyone, everywhere. And then the step to AI. So I think there is a sequence in this decision-making.
So it sounds like it would be useful if you're making the case about revisiting chest X-ray to talk about a hierarchy of how this technology should be considered. One of the issues that came up this morning was manpower or person power. Countries all over the world are having shortages of radiologists to interpret images. We've been talking about this for decades. I actually posed this question: can we think of any country that's ever overcome their manpower shortage? There are ways to do this, actually, and it's been shown around the world, but mostly in the UK. We did a demonstration project in Mexico that showed that technologists could interpret at a level of accuracy that could cut the workload for radiologists in half. Is this something that also should be pursued, that in fact we can have non-radiologist first readers in order to overcome the limitations of the number of radiologists?
I would extend that to AI as first reader. So even less cost, even more cost effective, right? So I think in chest X-ray is even easier, as we will talk about this tomorrow, because there are relevant incidental findings on CT. But I think this is just one or two images. And I think AI is further developed in chest X-ray, nodule detection, or fracture detection, or mass detection, than with CT, these incidental findings, where it can be very complex. This is my opinion. And that I think that there is a merit in discussing AI as a first reader and having a red flag, a yellow flag, and a green flag. And the green flag maybe don't need to be looked at, right? Because these are the normal ones. I know that you're promoting that for CT, but I think this is a discussion for tomorrow.
So I somewhat agree with you, but what we're hearing so far is that no one's really ready to turn AI loose to triage a significant fraction of the screen population to the report in the file. Yeah, well. Okay.
Yeah.
On the slide, nobody is talking about the constraints on supply. Nobody is talking about the constraints on the supply of residency spots, which is artificially constrained. Bob, hello? I'll wait for Bob to be done. What's interesting is the organizations are not talking about the artificial constraints on residency spots for the training and expansion of all kinds of professionals. And that's trained for a long time and despite growth. So instead of having, technicians or AI, as the solution, one of the pressing issues is an expansion of the artificially constrained training of doctors. There's a lot of whining about doctors getting burned out, which is absolutely the case, but nobody's talking about training more doctors. And that's really interesting because that's a financially constrained issues by organizations that control the spots. But it's interesting that nobody is talking about that. And it's not a matter of the money, as the studies have shown, at least in the US, the amount of money for residency spots is about double what it actually conceivably costs.
Yeah.
So rather, I'm seeing it over and over again, rather than discussing why is it that CT scans cost so much, we say, oh, well, we have to use chest x-rays. So I think there's underlying things that were, for some reason, conversation.
Yeah, I don't think there's any suggestion of using chest x-rays in countries that can afford CT, but I agree with you. This issue has come up all the time. It's a real head scratcher as to why this many years later, we're still holding the number of residency slots so low. I just don't know what kind of lobbying is taking place, but we're grateful right now in the US, we have an administration that wants to hear our good ideas and act on them. I'm making a joke, right?
Yeah. So I'd like to follow up on a couple of points that were made repetitively through the course of this.
We have, great.
Yeah. Right now, we have people in this audience have published on the image quality of CT scans done for screening in the NLST, as well as technical evaluation of image quality in reference conformance evaluation, quality control. And in both instances, somewhere in excess of 50% of the images are of substandard quality for appropriate interpretation by automated, by computational imaging. And you're doing a scan, you're going to manage the patient, and 50% of the cases, you're getting a substandard analysis. This is a unrecognized tragedy in our whole screening effort. There's been a transition. We've gone from visual interpretation to computer interpretation, and we haven't made corresponding, adjustments to the quality of the images that we're subjecting for this kind of. And if we don't fix that in places that are already making these investments, we're missing an enormous opportunity for this group to have a positive impact in screening.
So I agree with you. I mean, we did this with breast. We haven't improved interpretive quality, but under the MQSA, the images got vastly better. And they're probably in generally well suited for AI, but it seems as if this is a one-off quality assurance accomplishment, and that there doesn't seem to be much, at least leadership in questioning how to improve the quality of the CT images. So I don't know, We have one of our radiologists here.
Yeah, I would say there's some, oh, thank you. In the US, probably much more so than in Europe, the concern, in my view, the concern about image quality is much lower. I mean, in the US, you're still seeing organizations like Lungrad saying there's no benefit to doing quantitative imaging or, measuring lung nodule volumes as opposed to lung diameters, for example. And you hear them arguing this rather strenuously. So the idea that you need to have a better quality image it's not as important here. The Europeans, as far as I can tell, pay much more attention to this now. And I think, I think that this is, in my view, it's going to make a big difference. I even want to extend it more. I think that, in terms of CT, the quality of the CT scanners, what that's going to do is allow us to measure things better. I don't know how much better we need to detect things with CT at this point. We're getting to the point with CT of kind of diminishing returns. If you find the cancer, you can find nodules even with the lower quality CT scans at 2 millimeters and 3 millimeters. You use the newest, greatest scanner. Yeah, you'll see it a little better. But the amount of improvement in how well you cure something, once you're down around 5 millimeters to 4 millimeters or 3 millimeters, you're really curing the vast majority already. What you're not doing is your ability to measure change over time. That's where I think the real value of these newer scanners is. It's that aspect of it that I think the higher quality scanners will allow you to do. You'll be able to see change in a shorter period of time. You won't have to wait a year to measure the change. You'll be able to measure it in 3 months or 1 month or whatever. That's where the bang is.
Okay.
So let me just intervene for a moment because we do have a question from online viewers, and I want to give. I appreciate that we have online viewers with question. So the question is, how do digital tomosynthesis and low-dose CT differ in their ability to detect ground glass nodules? And what are the technical limitations of digital tomosynthesis?
That's relatively straightforward. You will detect ground glass nodules better with CT because the density discrimination is much greater, even compared to tomosynthesis. You just get a much better density discrimination. So you'll be able to see with tomosynthesis probably the non-solid or the ground glass nodules better than a plain chest X-ray. Because you're still getting a thinner section, you're getting a better contrast to background to contrast ratio. But the CT will do much better in terms of detecting ground glass nodules.
Julia?
Maybe a quick comment and a very short question. With a discussion on the X-ray, and especially the way how the discussion goes, there is only one thing that can make this discussion better. I love it. Somebody from low and middle income countries and somebody from lower human development index countries would make this so much more relevant, because for the existing infrastructure, I think this already been discussed, but for something setting new, what if setting something new, X-ray versus, and Jens went there already, liquid biomarker testing, what do you think about potentially setting up that study or trial?
I say wait until tomorrow's session 8. Tomorrow.
No, I think, David, I had actually the same question. You're talking about the follow-up time and see the growth of the nodules. But can you imagine, or do you acknowledge that we don't have the biology of the screen-detected nodules yet? Could it be possible that some biological features of the screen-detected nodules could indicate a different course and a different option for treatment? There are centers today that are focusing on immunoprevention, including our own center is talking about it.
I think you have a very relevant point there, and we're looking into that as well. And it's the big topic of overdiagnosis, right? So if you have diagnosed the cancer, you want to see with liquid biopsy whether the prognosis is. I think some research needs to be done, but I think we have another problem which we haven't talked about today, is the problem of overdiagnosis being like 25%. Some say 30, some say 20, and preventing harm, right, from unnecessary interventions as well. But the other topic in the low economic countries, chest X-ray versus blood test, right? That was your question. And I think we are right on the edge where a lot of companies are developing disease-specific markers. And we're actually looking into that as well. And I think it plays a role when we move towards what I said before, away from risk-based screening to a sort of blood test predefined risk-based screening. And then the next step would be, screening everybody with CT. But I think we're not there yet. And I think a step, I don't know whether it's intermediate or permanent, but an intermediate step could be to screen everybody with blood tests. The problem right now it's too expensive. The blood tests cost $200 for testing for lung cancer, for example, but potentially you could test, and I use the word cocktail of diseases in the future. And I think if the numbers go up, we solve hopefully the cost problem also. But I think there's a huge potential which is just unleashed at the moment.
We might have some disagreements here, but we're out of time. So
Yeah. So if Claudia and I would like to thank the speakers and the panelists for an outstanding session and discussion. And so we'll move on to the next item on the agenda. And thank you all as well.